tries to advocate for medical marijuana patients in this state. I've written this petition to ask the panel to add neuropathic pain as a qualifying condition under the Washington State Medical Marijuana Act, because I feel that the limitations that the current protections for chronic pain make it difficult for patients to who have this condition to use this treatment as a first-line treatment. As you know, the current conditions is intractable pain, limited to mean pain unrelieved by standard medications or treatments. However, current research is showing us that the use of cannabis or cannabinoid botanicals, if you want to think about it from the cannabinoid picture, it's a cannabinoid-containing botanical, have been shown to be as effective in as other first-line treatments for neuropathic pain, such as gabapentin. This is based on 3 double-blind, randomized, placebo-controlled trials that were conducted in California at UC San Diego, UC Davis, and UC San Francisco, funded by the California State Legislature, who earmarked $8.9 million to conduct these studies. 3 of these studies involved specifically neuropathic pain conditions in controlled double-blind conditions, and involved a total of 122 patients. In those studies, all of them showed statistically significant improvements in the patients who used smoked cannabis compared to the placebo cannabis in their pain indicators and using standardized scales of pain relief, the visual analog scale. Those are published in reputable peer-reviewed journals, and I've given those to the panel, Journal of Pain, etc. Dr. Igor Grant is the Vice Chair of Psychiatry at UC San Diego, and at the conclusion of their series of studies, he told the press at his press conference that cannabis should be seen as a first-line treatment for neuropathic pain. The pain conditions that were studied in these various clinical trials included HIV neuropathy in 2 of them, and then in one of the studies involved a wide range of neuropathic pain conditions, including diabetic neuropathy, neuropathy due to brachial plexus avulsion, so trauma, and neuropathy secondary to something called complex regional pain syndromes, so generally trauma-related chronic pain syndromes. So in all of these cases, it makes sense that patients who are diagnosed with a neuropathic pain syndrome should have the opportunity to qualify to try a comparative clinical trial, basically using medical marijuana as an empiric treatment trial. That's what we do in pain clinics, try something and see if that helps the patient. They should be allowed to do a pain treatment trial of cannabis prior to, potentially based on clinical judgment. It should not be the burden of the clinician to have tried opioids, gabapentin, tricyclics, and a whole range of other medications before using the cannabinoid botanicals. That is what the question my petition is asking the panel to sort of lighten for pain doctors who treat chronic pain in Washington. As a personal note, I'm a medical student at the University of Washington. I'm an MD PhD student, and I guess the panel was able to find some of my research articles that I've written as a result of some of my doctoral research studying the use of medical cannabis in Washington State and throughout the United States. And I've also worked in several clinics where physicians are subspecialty trained in chronic pain management. And I found that oftentimes it is most important for a doctor to have all potential treatments available for them to use when they're going forward to manage a patient, and that because I know a lot about cannabinoids and pain, this treatment, if we try to propose it, the idea that, well, the intractable pain sort of provision makes it sort of difficult for the doctor to go there. So that's coming from my experience of actually working with patients. I've seen this to be a hurdle. Nevertheless, it's very easily fixable because we do have an evidence base that supports this. Now, I understand that chronic pain is always a political issue, and constantly we're updating our definitions, trying to manage what medication limits are appropriate for opioid dosing. And this is an ongoing issue because, as you all know, probably are aware that opioid deaths are more causes of deaths due to that than motor vehicle accidents in Washington state currently. So I would think that it would be important for us as public officials dealing with medicine to try to make more options available, non-opioid analgesics available for patients when we have this epidemic of overdose deaths due to prescription opioids. I guess in conclusion, the politics of pain definition, of course, are part of this, and whether we're saying neuropathic pain, which you could really induce if you just technically if you hit your funny bone against a wall and you've injured your nerve, you're having pain due to a nerve, and that's technically neuropathic pain. But the idea behind this petition was sort of long-standing chronic neuropathic pain, and that's what the patients in the studies were all had. So I don't know how we sort of think about the definitions of pain to properly, appropriately understand that this is the kind of pain that we're trying to talk about. So maybe we might want to think about reforming the entire definition of intractable pain and moving into an idea of chronic pain and without any kind of limitation on having tried a whole range of other potentially lethal drugs. So I'd love your answer any questions or thoughts you have.
Questions from the panel?
Yeah, I have a couple of questions to clarify. I mean, my understanding is the petition is for pain associated with peripheral neuropathy. Is that correct?
Neuropathic pain of all etiologies, which include peripheral, but there were, I didn't specify peripheral in the petition, I just said neuropathic pain, which can be central neuropathic pain. Post-stroke, you have neuropathic pain, can be peripheral with HIV and diabetes, but I don't think it wouldn't be important to make that. I haven't actually written that word peripheral. Some of the studies involve peripheral neuropathy, certainly, but I also included other studies, and I included a basic science article, so we basically know why cannabinoids are effective in neuropathic pain. This cannabinoid system gets revved up, and these receptors need, when phytocannabinoids bind to them, there's reduced pain signaling, so it's pretty established.
So I'm getting a better idea, but I'm still trying to get a more clear thought. When you're talking about it doesn't matter, it's just neuropathic pain or central pain, right? You mentioned central pain. And then you add regional complex pain syndromes and plexopathies, right? So you're essentially, my understanding, you're really asking for any type of pain syndrome that we as physicians encounter. You would like to see medical marijuana be allowed as a first-line treatment.
Well, I'm not petitioning specifically for that. I did discuss the idea that I have some research that I've done on numerous chronic pain syndromes, myofascial pain syndromes, discogenic pain syndromes, phantom pain syndromes. There's a whole range of pain syndromes, and it depends on how you want to define it.
Well, that's what I'm asking you. That's